Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 infection control and other nursing home related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Navigating Opioid Use Disorder and Long-Term Care Facilities, Treatment, Screening, and Education. This is part 2 of a two-part series. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is Staffing Solutions, Lessons Learned, Equipping and Empowering Staff for Success. That webinar is a rebroadcast of a presentation we held on May 2nd, followed by a live Q&A. It is eligible for continuing education credit for both nursing and nursing home administrators. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again today.
Thanks, Kathy, and thanks everybody for joining me. I hope everyone's staying safe. I know I'm up here in Erie, right outside of Erie, Pennsylvania, and we just had some really bad weather blow through, and I know it's kind of affecting a lot of people, so I hope everybody is staying safe. So we're going to be talking about opioid use disorder. This is something that we are really not seeing a lot of in our long-term care facilities, but it is clear that because individuals who have a diagnosis of opioid use disorder are protected under the American with Disabilities Act, we are going to need to start admitting them into our facility. And I know it's been, kind of a challenge for a long period of time. And some facilities maybe have had difficulties because there's been some kind of, there's been, implication that discrimination is going on. So it's really time to kind of get ourselves ready to being comfortable with treating opioid use disorder in our facilities. And I will say, if we break it down, it's really not as scary as you might think. So we're going to be talking about the medications used to treat opioid use disorder, and then we're going to be talking about some processes involved in admitting these residents to our facility and continuing the treatment that they are receiving for opioid use disorder, and then potentially moving on to discharge them from the facility. So when we think about medications for opioid use disorder, there are 3. There's buprenorphine, which is the Suboxone, which the trade name that I'm sure you've heard. This is what you call partial mu opioid receptor agonist. We're not really going to talk about the pharmacology a lot, but what buprenorphine does is it suppresses and reduces cravings for opioids. So someone who has an opioid use disorder, craves opioids, they want to take opioids, and buprenorphine suppresses and controls these cravings. So as if you go on a diet or, you stop anything, smoking, willpower is only going to take you so far. It's a muscle that only lasts really so long, typically in most people. So it's not something that people can typically will themselves to stop using opioids. Similar to smoking. Some people can, but it is a very challenging thing. Right now, buprenorphine, which is Suboxone, can be prescribed by any clinician with a current standard DEA registration. So the rules have changed. So if you have a provider who has a DEA license in your facility and they say, I can't prescribe. So this is a physician with a DEA. The physician says, oh, I can't prescribe. I don't have an X waiver. X waiver is not in effect anymore. Any physician has to do 8 hours of training around opioid use disorder, buprenorphine, any MOUD, so medication for opioid use disorder. And then when they renew their DEA, they just click a box. I just recently did mine, and it says that you did the training and then you are able to prescribe buprenorphine. So any physician with a DEA can do that now. Methadone is different. This is the full mu opioid receptor agonist. Again, it also reduces opioid cravings and withdrawal symptoms, just like the buprenorphine does, and it blocks the effects of opioids. Methadone is highly effective for opioid use disorder, but I know there's a little bit of stigma, I think, associated with methadone, more so than buprenorphine. The issue with methadone is that it can only be provided for treatment of opioid use disorder through a certified opioid treatment program. So this means that if an individual is receiving methadone in the hospital for opioid use disorder, and then they come into your facility on the methadone, they have to get the methadone from an opioid treatment program. Now, I'm going to just specify that's for treatment of opioid use disorder. Buprenorphine and methadone are also used for treatment for pain. So that's a separate thing that we are not talking about here. We are just talking about treatment of opioid use disorder. Naltrexone is also used for treatment of opioid use disorder. This prevents and blocks the effects of opioids, that sedative effect and the feeling high effect of opioids. The problem with naltrexone is that it's very difficult because it shouldn't be started until an individual has been off of opioids for 7 to 10 days. So significant amount of withdrawal has occurred because if you do initiate it when the individual hasn't been off opioids that long, you're going to precipitate a significant severe opioid withdrawal, which we don't want to do to people. And naltrexone can also be prescribed to any clinician with an active license by a clinician. I just want to point this out. Now, the schedule of controlled substances, and I don't know if everyone is aware, but the DEA provides a schedule, classifies medications that are controlled. So our opioids like morphine, oxycodone, fentanyl, they are classified according to Schedule 1, 2, 3, 4, 5. And you can see the definition. Schedule 1, no medical use, lack of accepted safety. That's heroin, LSD, ecstasy. They cannot be prescribed. But the reason they schedule these is because some people do research on these medications. So that's why they are scheduled just for distribution and obtaining these medications. Then we have Schedule 2, high abuse potential. And there you can see medications that we prescribe day in and day out in our facilities: morphine, oxycodone, fentanyl, right? High abuse potential, high. Dangerous drugs, Schedule 2. So just to keep this kind of in mind, methadone is there as well, but morphine, oxycodone, fentanyl, all of those methadone, they're all kind of in that same high abuse potential. Then we have Schedule 3, which have less abuse potential than Schedule 2. And this is where our Suboxone or our buprenorphine is. We also have our Tylenol with codeine here, or ketamine. So these medications have less abuse potential than our standard opioids that we prescribe every day. Now we can go into safer, whatever. I just think it's something to keep in mind that our buprenorphine, which we're going to use, we use to treat opioid use disorder, has less abuse potential than morphine, oxycodone, and fentanyl, but we still kind of have that stigma attached to it. And then as we go down, we go down up in the schedules, we have less abuse potential. Something to think about. So methadone, it's long acting, it's an opioid agonist, so it stimulates those same receptors like oxycodone, fentanyl does, those same receptors that those medications act on. It reduces the opioid cravings and blocks the effects of opioids. It's available in liquid, powdered, diskettes. The liquid is what is used for treatment of opioid use disorder, and this is what is dispensed from the treatment facilities. Must be dispensed by a specially certified provider in certified facility. So if you have a resident who comes in, is receiving methadone, they have to kind of be set up with a special provider in one of these facilities, which may be difficult due to location, because those medications then need to be obtained from that specialty provider. They can be done meaning, typically it's the patient themselves that goes to the provider and gets the medication. But in the case of nursing home residents, they can send an individual who's like an agent. So it could be the nursing home administrator or the director of nursing, but it may be limited by distance. So if you don't have a certified provider at a certified facility within, driving distance that would make this feasible, then you can't accept a patient who's on methadone, because you can't get the methadone for them. Patients, again, taking methadone to treat opioid use disorder must initially receive the medication under the supervision of a practitioner. So buprenorphine, partial opioid agonist, again, diminishes the effects of physical dependency to opioids, available in a sublingual film, tablet, implant, or an extended release injection. What you will probably be seeing in the facilities is the sublingual tablet or the sublingual film. So that film needs to be placed in the mouth without any other medication. So that's really important. If you're doing buprenorphine, Suboxone in your facilities, it really needs to be given separately than other medications, because it needs to dissolve in the mouth. You can't just put that medication, that sublingual tablet, you can't just put it in the cup with the rest of the pills and give it to the patient and let them take it, because that's not going to be effective for the treatment of this, for opioid use disorder in this resident. The tablet needs to be dissolved in the mouth. It just needs to be able to be fully dissolved. It might take 10 or 15 minutes. And then after 30 minutes, the mouth needs to be rinsed to prevent any problems. So that's something to think about, that needs to be written into your processes, that's how the buprenorphine needs to be given. It does produce euphoria and does produce some respiratory depression, but there's a ceiling effect. So that's why there's safety. You take up to a certain amount and you might get some respiratory depression and euphoria, but it's like you hit a ceiling where you can't go higher, versus fentanyl, where you can go much higher, eventually to death with those symptoms. So that's why buprenorphine is safer. Naltrexone, again, you probably won't be seeing a lot of. I recently did a podcast where this was a recovery house, and they did actually take individuals who were taking naltrexone, and that was actually the only medication that they will accept into the recovery house, because there's no abuse or diversion potential for this medication. It is long acting. But again, patients have to wait at least 7 days for their short acting, and then 10 to 14 days after taking long acting to start this medication. So difficult in that aspect. So buprenorphine initiation, I don't see this happening right now in facilities where we're initiating residents on buprenorphine, meaning what we typically, when we initiate buprenorphine, we kind of have to stop opioids. So if somebody's diagnosed with an opioid use disorder, we want to initiate buprenorphine, we have to stop those opioids for a certain period of time, 12 to 24 hours maybe. I talked to one practitioner, they said they let, I think, 2 loose bowel movements happen, which is a symptom of withdrawal. So you have to have an individual experience some form of withdrawal and uncomfortableness. I don't know if this will be happening in our facilities, maybe eventually. What's important to note is that it may take several dose adjustments to get the patient stabilized in buprenorphine. That means once that resident is stable in buprenorphine and ready to come to the nursing home, we really need to be doing everything in our power to maintain them on that dose, because they're stable, they're treated, they're safe. Buprenorphine is a great medication to keep people alive with opioid use disorder. We know it works wonderfully. So that's what we have to kind of keep that in mind. Like, we have to do everything in our power to make sure that this individual remains stable on this dose. just something to keep in mind, and you can Google this. This is the opioid withdrawal scale. You may have individuals who develop these symptoms just who are maybe on opioids, maybe the dose was stopped abruptly, maybe the dose didn't come from pharmacy, so you may see people go through withdrawal, and you can kind of classify what degree of withdrawal they're going through based on their symptoms. And if you can see, going through withdrawal is fairly unpleasant. You get muscle twitching, you get a lot of bone and joint aches, you get diarrhea, you get vomiting, you get a lot of your nose is running, tears streaming down so it's very, very, very uncomfortable. So when we talk about transitions, this is probably what you're going to be faced with on this journey to admit patients with opioid use disorder who are being treated with medication. This is where you have to focus your efforts in the transitions, because this is when I'm sure you all see, I've seen many a time that things go wrong a lot with care transitions when a patient is coming from the hospital going to the nursing home. Communication is essential. We have a point person maybe who makes it really clear. This is exactly what the patient is getting. This is who's going to prescribe the buprenorphine, whether it be the provider in the nursing home, whether it be someone else. We need to be very clear who is prescribing this buprenorphine. I will say, when I practiced in West Virginia, I was the regional medical director for over 30 facilities. And I don't know how many times I got calls from patients, from providers who said, I'm not prescribing this medication, and the patient's already arrived in the facility. Like, that can't happen. We need to be solid in our plan for the resident to remain comfortable and stable at all steps. So all agreements that are required should be completed prior to the resident arriving. Start date should be clearly identified. Substance use disorder must be a secondary diagnosis. I don't know if any of you have seen this toolkit. This is available at the Massachusetts Department of Public Health. It is absolutely fantastic, and it describes each step, and everything that is going to be needed for you to start admitting patients with medication for opioid use disorder into your facility. It's wonderful. And I really love this flow chart. And it talks about what should be done at each step along the way. Now, I hesitate to give black and white advice and guidance, because every facility is different. Every facility is going to do this differently. So I think it's really important to take a look at that flow chart and really make sure you're covering each step when you start to write your processes and procedures in place, to make sure everything is addressed that needs to be addressed, so you are successful. So once the long-term care facility accepts the resident, a liaison should attempt to have a resident sign the substance use disorder agreement. The hospital should initiate a referral to a buprenorphine provider if the long-term care facility has an established relationship with the provider. And then always get your medical director involved. I've spoken with many medical directors who've actually helped write the policies and procedures for starting to accept these residents with opioid use disorder. Again, as I said, physicians are required to obtain 8 hours of training, and this allows them to prescribe buprenorphine for opioid use disorder. I'm going to say, once you start this process, I think you're going to be surprised that it's not that challenging. But just fear of the unknown, I think. So getting it started, I think, is probably the hardest step. And buprenorphine is probably the easier of the medications for opioid use disorder. Methadone is more challenging because you have to have the medication obtained. Like, you can't just obtain the medication from your regular pharmacy that you get every other medication from. You need to get it from a specialized facility. It needs to be a different provider, and there needs to be a lot of documentation. So more challenging to admit patients on methadone, but still easy to, not easy, but able, you can accomplish it with the right policies and procedures, getting all your providers involved, really getting your team involved. We are happy to offer any guidance in this area, to walk through your processes and procedures if you would like to get them started. So if you're thinking about a policy for medication for opioid use disorder, you really need to think about the referral acceptance process. Who is reviewing these admissions and who is deciding to admit these residents? And is the physician, medical director getting involved in knowing who is coming into the facility? Because you surprise your medical director and say, look, they're coming, they're here. It's just not good practice. You really need to kind of communicate well in that referral acceptance process. You need to find out who is going to prescribe, who is comfortable in prescribing. Will the resident sign an agreement for opioid use disorder treatment in the facility? How will the resident receive counseling services if they would like to receive counseling services? Do you already know what is available in your community for counseling services? Does the resident want to go to Narcotics Anonymous? What else is available for counseling for opioid use disorder? You need to have that at the ready to offer your residents. So, because we need to offer counseling services. It's a difficult diagnosis. Naloxone needs to be available in the facility. I'm going to be talking a little bit about overdose later in the slide deck. You need to talk about stigma prevention. You need to have staff educated about stigma around opioid use disorder. It still exists. And then the discharge process. Who is going to give the resident supply of their buprenorphine when they're discharged? And does the family physician or the primary care physician understand it, or whoever is going to pick up that, because we can't just let the resident, just hang out there. Okay, you're done with 2 weeks. And then you don't have another physician to kind of pick up the prescription after the 2 weeks. Drug interactions, always alert the consultant pharmacist. Please be on the lookout for drug interactions with buprenorphine. Really important. Pharmacists are fantastic. You just say, listen, we're going to be admitting residents on buprenorphine. Can you just give us a heads up if there's a drug interaction, especially when something is added? So when we talk about staff education, it's a knowledge gap. We know that this is a knowledge gap in skilled nursing facilities. So this was a study. It looked at an evidence-based curriculum. It was provided by a geriatrician, and all staff were invited to attend at a pilot facility. And they explained addiction is a medical disease, described medications for opioid use disorder. They incorporated non-stigmatized language, and they did a module on recognizing overdose symptoms. It was offered 12 times. 159 staff attended, and they did pre and post tests. And the mean post-test scores assessed confidence regarding learning, and post-test scores also increased specific learning objectives around defining addiction, medication for opioid use disorder, appropriate language around opioid use disorder. And staff really liked the education and had increase in their post-test scores. So it's fairly easy to initiate this type of training in your facilities. And if you have any questions around that, feel free to reach out. I provided links for education opportunities for staff around opioid use disorder. Again, if you have any questions, feel free to reach out to any of us and we will get you pointed in the right direction. Really important to think about creating a culture in your facility that does not, without stigma. So, we don't have stigma around a patient who has congestive heart failure or has COPD. So we really want to have that culture without stigma around the diagnosis of opioid use disorder as well. Important to incorporate harm reduction policies throughout your facility. I put link for the National Harm Reduction Coalition. You need to incorporate a section of opioid use disorder into your internal discrimination policy. This will foster a positive culture. Again, develop an assessment of staff perceptions around OUD, MOUD. It would be great to do an anonymous survey to figure out really what do they feel about opioid use disorder? And then anti-stigma posters. This Words Matter campaign website has really great anti-stigma posters for residents and staff, and just put up in your facility for everyone to see. This, again, is another toolkit around medication for assisted treatment for opioid use disorder, and then looking at stigma. Well, I think we underestimate stigma. So really important that you have these policies and processes in place to really have a really great culture to accept these residents into the facility. So this study looked at resident perspectives. These are residents who had opioid use disorder and they were admitted to nursing homes, and they looked at what the resident perspectives were around their stay in the nursing home while they were receiving treatment for opioid use disorder. And residents had a positive overall view about their stay, and they said that this might stem from stable housing, being an environment removed from daily stressors, and being in an environment where substances are less acceptable, which is fantastic. That's what we should be doing. But in this study, the residents said that they really would like increased access for counseling services for opioid use disorder. So I included this link. This is at SAMHSA, and you can go to this website and you can find counseling services in your area for opioid use disorder nationwide. So really important. I think it's also important to engage family and caretakers. Make sure that the resident agrees. Ask them, can we share information with your family regarding your opioid use disorder? Family and caregivers are, of course, important, play such an important role. Make sure, obviously, we have a list of prohibited items that they should not bring in. And then family focus groups would be great if you have a population of individuals with opioid use disorder diagnosis. Then organizing a family focus group really would provide wonderful input for treatment of these residents. Now I'm just going to end talking about overdose, signs of overdose: small constricted pinpoint pupils, falling asleep, slow, weak, no breathing, gurgling sounds, cold, clammy skin, blue skin, especially in the lips and nails. If you have a resident with opioid use disorder, if you have a resident who's taking opioids, or even any resident that is unresponsive and blue and not breathing very many times a minute, you should be thinking overdose. That should be in your differential. You know, when you say, oh, we check the blood sugar, you know, we check the blood pressure, you should be thinking to yourself, could this be an opioid overdose? Because we know that naloxone save lives. Fentanyl analogs have a higher potency compared to heroin, so larger doses of naloxone may be required. So if you suspect someone has been brought in or has taken a fentanyl analog along with whatever opioid they're receiving in the facility, and you suspect an overdose, you may need to give more naloxone. So you should always have it available in the facility. Call 911 immediately, then administer the naloxone, attempt to keep the patient awake, talk loud. I mean, I know probably this has happened many times in facilities where I've been seeing patients, and I think nurses and staff are like, she needs to be quiet, Dr. Storm needs to be quiet, but I yell and scream in the person's ear, come on, wake up, wake up. Like, you need to really attempt to keep the patient awake. Lay the person on their side, and then you stay with the person until emergency assistance arrives. Just a last kind of aside, treating pain. Patients who get medication for opioid use disorder should have surgeries, have acute pain, and this should be treated. Pain needs to be treated. So it's not like, oh, they're getting buprenorphine, I don't treat their pain. We make sure we treat their pain as well. Multimodal, non-opioid measures in place. Patients may need opioids for an acute period, a short period of time to treat their pain. It may be a higher dose because of the other medications they're receiving for their opioid use disorder, but should only be used for acute pain. So you're not layering on opioids chronically for these patients. Just want to close with a case. A 58-year-old with a diagnosis of opioid use disorder who's being successfully treated with buprenorphine 16 milligrams per day is admitted to the facility following a fall with a hip fracture. Surgical repair was done, and hydromorphone was added in the acute period because this individual had acute pain appropriately. And then eventually the hydromorphone is Dilaudid, eventually it was weaned off. Recommendations are made for rehab prior to discharge home, and accepting physician at the skilled nursing facility agrees to prescribe the buprenorphine for the resident. Good communication. Nursing facility faxes the opioid use disorder agreement to the hospital, and the resident signs it in the hospital. The resident saying, yes, I agree to be treated for my opioid use disorder in the nursing home. And then it's faxed back to the facility, so the facility has it. The hospital then should create a flow sheet for the buprenorphine information, the start date, the last dose, and should fax that to the nursing facility as the resident is leaving the hospital to go to the nursing home, should be faxed to the nursing facility. Resident arrives at the skilled nursing facility, and attending physician arrives to assess the resident, writes a prescription for the buprenorphine at the maintenance dose. The attending physician also writes an order for consultation for the psychologist at the facility for ongoing counseling and support. The pharmacy delivers a 2-week supply of the buprenorphine naloxone, and the resident continues on therapy during rehab. The resident discharges home in 2 weeks, stays in the nursing facility for 2 weeks, and is discharged with a prescription for buprenorphine naloxone with enough supply to last until the resident's appointment with the prescriber in 4 days. So great communication. Take-home points, very prevalent in our patient population. Important to keep in mind. Medications used to treat opioid use disorder can suppress craving and reduce risks of overdose. Long-term care facilities should adopt educational programs to help staff understand and learn about opioid use disorder and to reduce stigma. And then we talked about some screening tools in our last session. So any questions?
Thank you, Dr. Storm. We don't have any questions so far. So while we wait, I'm going to run over some closing items. If anyone has a question, please submit it using either the chat or the Q&A tool in your Zoom menu, or you could also raise your hand if you'd like to ask your question out loud. While we're waiting, I'd again like to invite everyone to next week's webinar, which will be a rebroadcast of our May 2nd webinar, Staffing Solutions, Lessons Learned, Equipping and Empowering Staff for Success, followed by a live Q&A. And as I mentioned earlier, that webinar is eligible for CEs for nursing and NHAs. And if you're interested in joining, that webinar will be held the same time and place next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and our webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org, and I will get you on that list. And now I will look to see if I have any questions. And I'm putting my email and Dr. Storm's email in the chat. And you also have Dr. Storm's email up there on the screen. And I don't see any questions coming in, so I think I can wrap us up. Dr. Storm, do you have anything you would like to add before I close us out?
Just if anyone gets started in this process and really would like some support and help, please feel free to reach out. We're happy to guide you in this process. You can reach out to me or any of your quality improvement specialists that you work with, and we'll point you in the right direction.
Thank you, Dr. Storm. All right, so I'm going to go ahead and close this out for today. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show us a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Dr. Storm, I'd like to thank you for joining us again this week and for this great presentation. And I'd like to thank all of you for joining us, and we hope to see you back here again sometime soon.